morning from Miami Beach, home of Neurosurgery TV. It gives me a great pleasure to introduce Cyprian Ionita, a PhD from University of Buffalo, Jacobs Med, who gave a presentation last week on artificial intelligence and neurosurgery, and that's going to do a presentation tonight on complication detection during endovascular procedures. And we're tremendously honored to have a couple of very noted Chinese neurosurgeons with us. Hello, Ben.
Hello.
Yeah, Ben's at, can you just say a few words about yourself, Ben?
Yeah, I'm very interested in this topic, and I think it means some future for the neurosurgery. Yeah.
Okay, very good.
Yeah.
Can you introduce your associate, Ben, that you told me about?
So I'm just listening because this is my first time.
Oh, I know, but you're
yeah.
There's an associate on the panel that you said is from Beijing.
Yeah. Professor Zhao Yuanli from Beijing Tiantan Hospital, and their hospital is so big, and the department they have around 170 neurosurgeons.
Cyprian, I would say you hit a home run.
Thank you.
Okay, Cyprian, welcome, and it's all yours.
Thank you. Okay, so can you see this?
Yeah, perfect.
All right, thank you. So we started a series of 3 lectures on use of AI for neurosurgery. Last week we focused on the use of AI for stroke, and we dealt mostly with CT data and how we streamline the patients by detecting fast intracranial hemorrhages, large vessel occlusions, aspect scoring, and then better ways of estimating the infarct core versus penumbra for selection of the patients for mechanical thrombectomies. Today, we're going to go one step farther, and it's what's happening after the patient shows up and it is selected for treatment. I have some disclosures. I'm supported by National Institute of Health and National Science Foundations, and I have some patents relevant to this work. So last time we talked about the AI medical applications, and we thought that for stroke, we will be dealing with demonstrate equivalence with human performance, optimized workflow, faster diagnostic, and patient training. Today, I'm going to focus on complication detections during the procedure. And next week, I'll show treatment planning and treatment guidance with prognosis of the surgical outcome in real time. So a little bit the work that I'm going to be talking today, it is what's happening during image-guided endovascular interventions, where you take a catheter under fluoroscopy and you treat some sort of lesion into the brain using different devices. And mostly, I'm going to be focusing on the aspects that potential complications and detections of those complications in real time. So during these procedures, the only way we can look at the vasculature is with a process like shown in here, which is called digital subtraction angiography. I apologize if this is too basic for some of you, but I'll go fairly fast through some of these procedures. And until now, a lot of these procedures have been used to just look at structure like stenosis, arterial venous malformations, and intracranial aneurysms, etc. So very little is paid or it's used during this procedure to look at the quantitative aspects of the flow. And there are some challenges that I will go through in these presentations and how we can bypass them using some AI aspects. So bottom line, at the end of the day, these things are used mostly for structural and not enough for functional and information. So last time we were in this domain, what's happening before we got to the angiographic room and during the procedures. Now we are in the angio room, and during these procedures, we have systems like this, biplane systems, with where is an X-ray detectors on 2 directions, and these are the kind of the data that we acquire. The key aspect is that if we are here in this domain at the CT, we take the CT data, we can upload it into a cloud, we can upload it into a different kind of a program and analyze and do some sort of prognosis and predictions. But when we are in the angio room, everything is contained. We do not have access to this data unless we upload them into the PACS of the hospital, and then we analyze and we come back to the doctors and tell them what's going on. That can add easily between 5 to 10 minutes. That is a big no-no in the neurosurgery field, especially when you have catheters inside in the arteries of a patient and so. So the general approach, it is we do the procedures, we do the treatment, and then we wait and see, take them to the CT scan, and we diagnose. And it's sort of a diagnosis amaurosis during this time. So what we can do with this nowadays, it is we can add some quantitative aspects, and no worries, I'm going to go in full detail about this quantitative analysis. We can process some of these images, and then using AI, we might be able in real time, in a fraction of a second, tell the doctor if something went wrong. And a lot of the things that I'm going to be focusing today, it is in deficit in flow. And this can be occur that you dislodge a plaque, you inject an air bubble, or you place a device that blocks a small perforator or a bunch over a smaller artery that you shouldn't be blocked, like a flow diverter placed over the ophthalmic artery or so. So the idea is that can we detect this in real time and tell the doctors, hey, you should check this area because the flow has been decreased in here, or something it's fundamentally not right. And they can look at it, say it's fine, or can take the patient to observation immediately after the procedure. And again, this is for an AI system that resides on the C-arms. It is fundamentally different from something like I shown last time, where anyone can develop this kind of a software, have them on a cloud, and do this kind of a processing and diagnosis, etc. So I will just go with a really quick 101 quantification of the flow in planar angiography. And the idea is that even when we look at this kind of angiograms, as the contrast goes through this system, it follows the laws of physics and convection. And as the curve goes, as the contrast goes through this system, it flattens and it widens. This is exaggerated, but it really, in reality, this is what it happens. And if we have fine analysis kind of systems or data or software, we might be able to pick up on these subtle differences, which sometimes they're not quite obvious for the human eye. And what we do, we parameterize these curves. We take all sort of parameters, and I will just choose today a few of them: mean transit time, time to peak, time to arrival, area under the curve, etc. But you can parameterize these curves in about 24 ways. And everyone has its own approach in doing this kind of analysis. John, can you mute? Okay, thank you. So this is kind of the way the software works. It takes the angio data, it does some sort of a processing to make them smaller, to increase the processing ways. It looks at every single pixel into the image, like we look into the CT and CT perfusion. Then we discriminate to eliminate some of the background and make sure that we count only structures that matter. And again, this is to speed it up. And then Sometimes we use fitting data because it takes it smoothes it out and it takes care of some of the noise. And then we calculate for every single pixel into that image this kind of maps, and you get pictures like this. And what is this thing? What are these pictures in here? It is a like you're looking at a object with different filters. You are looking at the vasculature with different filters, and every single one gives you one piece of information about the hemodynamics and the flow into that area. Peak height tells you how much of the contrast is going in. Time to peak, it tells you what is the delay. Mean transit time, it tells you things like how long a particle of contrast goes into an area and stays there. That can be related to the stasis if you're thinking of the aneurysm. So every single picture that is in here, it tells you one story about the hemodynamics, but not only it tells you things about the physiology in an area, it tells you also where it's located. So this kind of maps gives you information about location and the function. There is a big problem with them. The problem is that these are planar. So you're looking through the entire skull, through the entire brain when you're looking at this. Everything is overlaid. And the signal of the lesion of the or of the disease, it is very small, which makes every single of the parameters weakly correlated with the underpinning disease or with the physiology. But it is a lot of data. So what we are going to do now, since we cannot really correlate one parameters with outcomes or with the severity of the disease, we're going to go into data-driven models in order to use all this information in context of a large amount of data that these hospitals are generating and see if we can solve the problem. So this kind of angiograms, I would say per patient, you can take about a dozen of them per procedure. So, and a lot of them are getting discarded. And the idea is that we sit on a humongous trove of data set. It's golden. Most probably, it is more data than any other imaging modality in the neurosurgery department or in the cardiovascular departments. And yet, we're not using this. We're just pass it along. Some of it gets deleted, and we just save snapshots of normal DSAs. So, and that being said, first questions that we're posing, as we said before, AI, it is new to the medical field, and if we do not take baby steps into it, it will be uh, potentially discarded. So there are certain steps. First, you show that it's possible. Then you show that it matches the human performance, and then we move and say we can do better. So in this study, what we looked at is we posed the following questions. Can the AI grade um, the perfusion following mechanical thrombectomy? In this case, we're using the modified Tiki scores. Following a mechanical thrombectomy, there's different grades ranging from no perfusions to grade 3 of complete perfusion. So a patient that comes with a large vessel occlusion, they place a clot retrievers and then try to pull the clot out. And after each one of them, after the first pass or second pass, sometimes they do another angiogram and grade that patient based on this kind of semi-qualitative, quantitative assessments. And we pose the questions whether the AI may be able to do something similar. And in the same way, we took every single angiograms and generated several maps for every single one of them. So if you look in this case, these are a map of peak height, area under the curve, time to arrival, time to peak, MTT, and so far. So based on these maps, if we look at them in general, we can't quite say what is the status of the reperfusion. So for us, what we are going to do it is have all this angiographic parameter or individual them and combine them in order to have an improved predictive strengths on these cases. So if you remember from last time, we are in this context. We want to use the AI and ask the question, what is this? And before we had cat, dog, and so far and so on. Now we have Tiki 0, Tiki 2, Tiki 3, Tiki 2b, and so far and so on. And we go through an iteration where we try to find the function that takes this image into a label preset and which has been kind of provided by the neurosurgeons. And we keep going through this iteration over and over again until the AI is going to be able to identify this is a dog, and for us is going to be this is an empty key of 2b or so. So this is kind of the iteration that we showed last time, and I'm not going to go into too much of a detail breaking this down and how the AI is taught and so, but that's just showing it to give a perspective of how the process goes. Now, the problem it is we have a whole bunch of maps, or we have, in this case, two C-arms. And the idea is that we have different options in here. We can train a neural network or a program like I showed you in there per map. And then we have all these AI structures or all these AI parameters combined, or we can have multiple maps for each of these sources and then combine them per view. We take lateral versus AP view. And this kind of games can be played not just with the imaging. A source like this, it can be, for example, you're looking into the EMR and you want to bring some patient characteristics. You might want to have a complications based on age, smoking, drinking, etc., and so on, BMI. Every single one of these networks can be different. And this, in this case that I'm going to show in here, is just based on the hemodynamics and complementary information that comes from the biplane. Now, for these weights in here, there's different ways you can approach them. You can count them equally. You can count them that they are all normalized. They add to one contribution, or you can do again a retraining. So you have all this individual artificial intelligence maps, and this can be done for each one separately. And then you go again through a final training where you recalculate these contributions from every single of the maps. So we have done a study using 383 DSAs, and we're looking at patients with occlusions from ranging from M1, M2, and ICA, also tandems and a few others. And these are the distributions of the MTK scores that we have used. Our neurointerventionalists were involved into scoring every single DSA. And if we had cases with disagreements, then we had them convene and decide what's going on with what is the correct MTK score. So the biplane data has been acquired from every single one, from every single image plane. And then I'm not describing in this presentation, but we do a lot of image processing, and we do a lot of other things to account for surgeons' variability, because two surgeons are going to inject differently. And we also going to account for different imaging views, or what we call foreshortening, because those C-arms can be pointing in all directions. But I'm not going to insist on those technical aspects. I'm just going to focus on to the implementation, clinical applications in here. So you have to look at it and be careful about, because these DSAs can be very long. you can do some image processing to use only data enhancing structures that you are interested in. Because if you keep the entire sequence, sometimes you might run into troubles because you add structures that do not matter. And it's just if you add structures that do not matter with regard to the task you want to have, then you need a lot more data. So as a rule of thumb for the AI, whatever you think and what your gut feeling, not your gut, your experience, your reasoning actually, uh, based on years and years of doing this kind of cases, whatever it doesn't make sense, take it out. Just keep the things that matter in order to train the AI, and then things are going to become a little bit easier. And we went through the same process, and we get these maps for every single one. For lateral, for the AP, anterior posterior, and for lateral. And then every single one goes into this training algorithms where that uh, paradigms that I showed you as a dog is done for every single map, where we train versus the labels that the doctors have provided. And then we assemble them and we run it again in here. And we run it again in here in order to recalculate those weights. It's to decide how much weight is this map going to contribute to my decision, how much this map, and how much is the lateral, and and so far and so on. And then we are going to do a classification, and in here I'm going to do it in just showing for just the two groups. So here is kind of the architecture, and is just going into an input. We do some convolutions, and these are in general some sort of a simple convolutional networks. We are usually training the data set on about 70%, and then we do a testing set 20% that is never used for the training. Again, we never use this kind of things uh, uh, for the training in order not to bias the network. And then there are other things like details of the network that you use: training optimizer, ADAM, loss function binary, cross entropy. And this is important because next week I'm going to talk about how we can add some physics into this more than just binary cross entropy. And uh, and um, um, uh, and once is it trained, we are actually for every single training. I apologize. We do what is called the Monte Carlo cross validation, and this is a requirement from Radiology Society of North America. The RSNA has published a set of about 10 rules that should be used every single time you're going to do an AI training or validation. And among some of that is that you need to make sure that your data set or your AI is not trained using just a lucky of splitting of the cases. And in this case, we split it 20 times, and we run every single time the training, and we test it. And then for every single one, we go and evaluate it using all sort of things like area under the curve for ROC, sensitivity, specificity. Matthew correlation coefficient is very important for AI training. And so I highly recommend people that do this kind of analysis to go and use this approach. And here are the results. The just a simple kind of like feasibility study onto this, it just shows that this kind of AI techniques can come and predict really well this kind of outcomes. You look at an accuracy and you have an 82.7. You have an area under the ROC, it is about 0.86. The key is if I would take two interventionalists and I will ask them, what is this, the MTK2B or MTK2C? most probably they will kind of also diverge in there. So I think as we're looking at things to kind of like unify on these labels, we might be actually able to get even better prognosis, because at the end of the day, the AI, it is trained on these images and what we tell the AI that these images represent. If the doctor says it's to be, MTK2B is going to say all the next one is MTK2B. So you see, there needs to be some sort of a consensus into the labels in order to kind of like have this AIs properly trained. And here it's an example where we take the images and we look at them and we predict in this case, hey, we are confident with a 61% that this is an MTK2B, 2C, or 3. Um, what is key about this is that all this, it is stealth. It's supposed to happen on the C-arm itself, onto the software. The doctor does not need to go and click this, click that, or do any kind of adjustments. It is right there happening in the background, and in a fraction of a second, it just comes back and tells them this kind of scores and evaluations. And again, this is just the initial part when we start say, hey, is this possible? And indeed, this kind of analysis in here put kind of like showed without doubt that we can evaluate this kind of really fine structures and so. But the next thing it is, well, can we do it even better? Can we go to the next step and do something like, can we do better than humans, or can we match the human performance? And in order to do that, we need to do two things. We need to actually not only to be able to say, hey, there is a deficit into this area, but where is it? And that is definitely, if we look at the CTs, we have this kind of things pre and post diagnosis for infarct cores and ICHs, where you can kind of look and say, hey, here it is a problem. Here is an ICH, and here it is the infarct core, and here is a penumbra. And so, can we do kind of the same thing again into the angio suite? And the problem with that in here, if we look at this kind of yeah, injections, and we have going from arrival all the way through the end, and we pose the questions, where is the problem in here? A very experienced neurosurgeons probably will be able to say it. An entry level or a fellow might be struggling with it. Nonetheless, can we have the AI capable on doing this? And the way we approached this is that we went and automatically placed this kind of regions of interests into the onto the skull, or onto the AP and lateral view of the C-arms. There is 4x5 into the AP directions, and there is again 4x5 into lateral, which kind of like, if you think about in 3D is 20x20, it's about 400 this kind of regions of interests in there. And we have done a study where we used about I think in this one we it wasn't too big of a study. We used 25 subjects in here, and we have looked mostly at patients that got TK2B and TK3 after the mechanical thrombectomy. And the study goes like here. So these patients went for mechanical thrombectomy, and immediately post-procedure, we had them have an MRI. We went and took FLAIR data and went and segmented this kind of images, and then we have recreated views, 2D views, or lateral and AP of this infarct cores to match the DSA data, as you see it in here. So we took this kind of now projected location of the infarct cores, we overlay it over the DSAs, like you see in here. And then we looked at exactly the same parameters. What you see in here is time to peak, mean transit time, bolus arrival time, area under the curve. And we have looked at patients or areas that had deficits in flow versus the ones that didn't. And when you start looking at this, you start seeing that there is already a correlation in between this, which means that you don't need to go all the way through like very complicated artificial intelligence kind of a software or the one that require a lot of training. You can go to something simpler, like something maybe like a SVM, support vector machine. So we we take this all the data, we find this what is referred as hyperplanes to separate the regions of interest that have deficit in flow versus the ones that don't. And then we have trained it and apply it for new cases, which obviously again had MR immediately post procedure. And what we have figured out, we found out that this kind of a procedure, this kind of approach, not only can tell you that there is a problem with this kind of with a flow, but it tells you the areas affected by this flow deficit. And when we look at again, what is the ability of the an AI kind of a software to not only tell you there is something wrong, but also locate it, we start seeing accuracy of about 80%, area under the ROC 86, 0.86, which is even better, if you remember, than some of the things when we looked at the global aspect of the flow. So, and it's better because I think we had very clear labels, also simpler labels, infarct core or not infarct core. Well, there we had about 5 or 6 grades in the modified Tiki scores. The more labels you have, the more difficulties you have. The more data you need to train the AI in general. So the idea is that now we have this kind of an issue, this problem, but this kind of a solution, sorry. But what we try to do next, it is actually in the real time, again, in the Angio suite, not only tell them about the doctors and the neurosurgeon interventionalists about, hey, there is something wrong in here, but have a neurologist label every single one of these ROIs. Neurosurgeons, especially some of ours, they told me, I do not need you to tell me this. I know exactly what this patient is going to happen to them when this is at the end of the day. Others, they said, hey, this is really great. I would like to know it because if I see a clot in the M2 and you kind of like give me an idea about what deficits these patients might have when they come out, I might be actually weight the benefit of these patients versus the risk of putting a clot retriever into the M2 and decide to go for it. So this is indeed it is debatable, and I think you can already look at it and see the problems that might raise within the context of the regulatory office, like Food and Drug Administration and so. Um, the other ways to look at it, we might actually not look at this kind of deficits into the potential deficits into the patient, but actually do an MRS score and a modified ranking score, and that's for uh, um, that's another outcome for this kind of a treatments. So the next thing is a little bit different. Um, and now we're going to move even farther. Now, tracing the ROIs is cool and so, but can we bring the kind of like the performance of the CT or MRI into the angio suite. And that is a different kind of a problem. And you remember last time I showed you this where we try to look at an image and then we segment it and we say, hey, ones are a person and three are plants, two is a purse, building and structures are on the side. What if we could do something like this also for this kind of images into the angiographic suite? And just to remind you how this is done, it is so done. It is used so-called convolutional neural networks, where we have some filters or it's some mathematical filter like this, and we pass it across the entire image. We do all sort of calculation to that. Then we do something we call as pooling or an upsampling layers, where we take pieces of the images and we compact them and we make them smaller and smaller and smaller. And you see structures like this as it goes. And what's happening, you take the image, you apply those mathematical filters and you make them smaller, and you apply again those mathematical filters and you make it smaller, and so far and so on. You get in here at this bottom layer where you kind of like encode the information in the image, and then you go back up again and you output an image that identified every single kind of a structure in there. So we try to do the same thing, and this is actually how we started. We were very ambitious in the beginning. We thought we're going to take these images and we are going to output stuff like this, where the infarct core is. So we took, again, parametric imaging maps. We took ground level label infarct cores, and we wanted to have the network or the AI predict the location of the infarct. And in order to do that, again, we went to the patients that we had the data and geographic data. In immediate after procedure, we had the FLAIR MRIs, DWIs, etc. And what we did, we take this data from the MRI, we rearrange it to recreate like a view, a projection, and you kind of like see the data in here is quite degraded, but it doesn't bother us since we are kind of like see pretty clear where the infarct cores are and so. And what we do, we take that data and we co-register it with the AI, with the data from the angiography. And then we train the AI, we take those labels and train this kind of, in this case, you look at the mean transit time, which is the average time it takes a particle to reside into a certain area. So we take those kind of, we take this kind of maps and those MRI co-registered data, as you see in here, these are the masks. And now we train the artificial intelligence, in this case, something like a UNet you've seen over there, in order to recognize that this pattern in here corresponds to an infarct core. And this is what the AI, for example, gives us. It gives us a probability field where it tells you that, hey, here I think it is the infarct core. And you can see it, we might be able to do this in real time. That's the idea, is to do it in real time during the procedure. As you take your catheter out, you take your clot retriever out, you can navigate it to the area, do the changes, do the procedure, and it will tell you in real time what kind of a flow changes has occurred into this area. And when we compare, for example, with the projected views of the MRI, these are the kind of the correlation. I have to say, these were our greatest. It was about 2 years ago. This thought was our thought initially, and we thought it's going to be a walk, not a walk in the park, but quite straightforward. And it wasn't. And then that's where we decided, hey, let's step back and we go through what I showed you in the first application, second application, and now we're, I think, ready to go into back to this problem and solve it. because it's not always working as well. But I think now, 2 years later, we have a lot better understanding on how to do this. And I have to say that it is extremely important that you understand that just taking DSA data from the C-arm without doing accounting for all the things, for differences in imaging, differences in hand injections. If everybody in this world will inject with a automatic injector, I think the problem will be straightforward, but it's not. And I highly doubted that a lot of the neurosurgeons are going to do for every single angiogram they are going to take, they are going to actually connect the automatic injector. So you just need to take an image, a snapshot, or a sequence, see what's going on, move, and keep moving. So as I said, the issue with the data that I show, or with the uh, um, analysis that I've shown you, is that we are constricted to the 2D world. And we are constricted to just planar imaging because we want to save dose. We cannot do a CT scan to get every single time to do a CT fluoroscopy to guide catheters and so, because the dose is a problem. But there are ways to go around this issue. And I want to show you where we're going with this to even improve the AI performance and bypass this 2D limitation and get into the AI-driven reconstructions to help us with this kind of processes. So if you look at the a normal cone beam CT data, this is the reconstruction. But when we acquire views of this, just one slice, when we look at the projections, this every single line, it is almost like a DSA or an angiogram in here. This is kind of like what the data looks like. And the idea is that in order to get this, you need about 180 degrees of projections, or that's what the CT scans do around. One of the questions that we posed is, hey, what if I have only a little bit of the data? Can we actually get back this reconstruction? And it is, from the point of the AI, is that I show you only the nose of the person, and somehow the AI reconstructs the entire face. It's a little bit in a way in that form. So go from full-fledged data to fragmented data and be able to reconstruct the entire information. And this is done with what is referred as a generated adversarial networks. And in here, it is exactly the same as we shown you before. That data in, something, give me back the actual good image. And it's again one of those UNets that I've shown. But unlike this one that we showed you before, there is another network in here that analyzes every single image that this guy generates. It is like this, it's a thief or a money counterfeiter that tries to make fake money. And this in here is a police trying to figure out which one is fake or which one is it's a legit uh, legit money. So and we keep this training where this one tries to fake this image and make it good, and this guy tries to discriminate until we reach a peak. And when we reach the peak, we stop the training and we take this part from here and we use it to reconstruct the data. And in here, you can see, for example, data that is ground truth. This is what you can get without with just fragmented data. It's bogus. You pretty much, you see nothing in there. But when you apply this kind of trained networks, you get back the entire information, and you get it with about a third of the data that you have. or in this case, maybe 45 degrees. And the idea it is to go even smaller and smaller in such a way that even when we have maybe just two views or a little bit of a previous information about the 3D data, we may be able to bring the 3D information back into the angiogram, not only for diagnosis purposes, but also for guidance. And if you're wondering, well, is this guy telling us the truth? We took that CTD trained or that GAN network, that AI that was trained on sparse data, we applied it to phantoms that we know precisely what it is and everything that works in there. And we lost something in here, like this fine structure. But then when we looked at the gray values, and it will come back to the Hounsfield units, you know, degraded after using just a little bit of the data and classic reconstructions. But once you apply the AI, it's coming back. And what you have to realize, this is, again, it's about 150 milliseconds per slice. This is really, really fast happening again. And look at the linearity. This is the linearity before taking was normal scanners, and this is the one that we take after using the reconstruction algorithms. So how can we use this into the angiogram? Well, here is the results for using it on the actual reconstructed data on a C-arm. If you're going to take a full scan around, this is a ground truth. When you have things like this is the vasculatures that you have. But then the idea is just use the 45 degrees. It's like you do the arm, you do 20 degrees into this direction, 20 degrees into this direction. And a system like Siemens can do this kind of things. You just swing the arm a little bit, you take your angles. If you try to reconstruct that, forget it. But if you try to apply a artificial intelligence reconstruction, it brings you back almost the entire 3D. And again, we think that taking this into the next step of reconstructions and combining it with AI for prediction of infarct core, we try to move into we are going to try to move into predicting delayed cerebral ischemia following subarachnoid hemorrhage, and maybe looking into the AVMs and predict, you know, for which artery you should go first to block it, and so far and so on. So this all together, and for the AVM in particular, 3D, it is extremely important, and so. So to conclude, what we are trying to do in here, it is create or have an AI that is not in the cloud, that is not somewhere on your laptop, it is on this system. It is right here, communicates directly, and analyzes every single image that it goes through. It does the magic, its own magic in the background, doesn't bother anyone, and then only on the same screen that you have in the angiogram comes and makes recommendations. It's not taking over the diagnosis capabilities or over the ability or over the practice of neurosurgeons. It's just enhancing their practice by saying, hey, with a probability of 60%, I think something has occurred into this area. Please check it. You can check it in the angiogram, or you can immediately say, follow this patient into the ICU, give me an MRI. We showed that how you can use this into the internet on the C-arms. The idea is to use it during the procedures, kind of like make the recommendations without bothering the surgeons. They can accept them or can choose to follow them up. They are really fast. Everything happens in less than a second. And this is, I would say, the biggest key. We cannot work this by ourselves. We need to work this with the people that make these C-arms, with the Siemens, GEs, Philipses, and Canons of the world. because then it's losing its value overall. So these are the faculty that make this happen and help me with this. The Dr. Adnan Siddiqui is our Director of Research. Dr. Elad Levy, it is our chairman. And actually, all the software that I've shown you today and all the work, it's done by these people. These are the PhD students in my group. Um, and a lot, really, the more senior ones, I have to keep up with them. They become so good at programming and making these networks and analyzing them that it's sometimes a challenge to keep up with them. We are also looking really eager to collaborate with others. This is my email, so email over there. You cannot build good AIs or relevant AIs with data from only one center. As a matter of fact, we cannot do a proper AI or that applies to a large population with data from only one country. So the idea is that without a large collaborations, these things will not go very far. We're not as fortunate as other AI applications where people post billions of pictures of dogs and cats and other things and tables and things on the internet. Our data is actually quite restricted. And I understand that there is a huge problem with patients' confidentiality. And I think only by kind of like bringing it up over and over again to this people, regulatory people, and so maybe they will start understanding that we can work around it without actually revealing anything from the patients, any information. We just need the images, and we need to know what happened or what every image represents, and hopefully this will move forward. I am done and I'm open for questions.
Okay, fantastic, Cyprian. It's great to bring your world to our world of neurosurgery, and you have a really good audience here. I mean, a fantastic audience. Louis, are you there? I know you're a little late. Are you there, Louis? Louis Borber.
Yes, I'm here.
Hey, Louis, good to see you.
Good to see you.
Yeah, I know you came late, but I just want to introduce you. He's reaching a lot of people, and you're a very important person to reach. It's good to have you here.
No. I'm humble here. I'm here to learn.
Okay.
Very impressive work. Very impressive work.
Okay.
Thank you very much.
Okay.
As I said, these are the folks that make it happen.
Okay, it's open now for comments or questions.
Oh, Professor Shu. Bing Shu.
Hi.
How are you? Good to see
Hi,
you.
Professor Luis.
How are you?
Fine. Cyprian, thank you
Yes.
for your fantastic presentation. So, did you ever analyze the chronic ischemic conditions like moya? Because most of your work was analyze emergency ischemic patients,
Yes.
like stroke, the MCA or ICA occlusion cases.
Yes. So the ICAD and moya, it is actually ongoing. We have one of the students looking into gathering the data, and I think the bottleneck, as usual, for these things, it's always a database. It will take maybe like half a year to go into the PACS of the hospitals, download these images and label them, and then start thinking about looking at them, try to make sense. And if you see things visually, then you go to the AI. So ICAD and moya, it is right in the beginning. And we have the questions, especially for ICAD, is what to do. Should we go and do the angioplasty? Should we just observe it? Should we put a medication and those kind of things? But yes, it is on one of the things that we would like to tackle.
Yeah, I think it's also helpful in analyzing the effect of the surgery. You can see the reperfusion and the improvement of the perfusion after the surgery. Yeah, use this AI, I think is also very helpful.
Yeah.
Okay.
So thank you. Yes. And as I said, the data set, it's everything, and especially labeled data set with known outcomes.
I'm just gonna bump you off the screen share there. A second, there you go. Okay, there you go. Okay, more comments, questions for Cyprian?
Let's make one supposing here. We are using this for endovascular procedure.
Yes.
But use the ICG from the microscope. See the intraoperative angiogram with ICG. Do you think it is possible to predict something similar that you have?
I know the folks at Johns Hopkins are looking into something like this, and using just a microscope. Not sure that I will jump into let's put it this team. I'm not sure that we are going to jump into the. I'm not analyzing the optical aspects. I know that there are other folks that are doing it. It's Professor Dunn in Texas that's doing speckle imaging in order to analyze the flow through vasculature and to the tissue. There is Professor Yordakita at Johns Hopkins University that's developing AIs for microscope and robotic surgeries. So there are folks that are doing this kind of things. However, for us, the only thing that we were asked for is guidance before you even actually go and open the patient to tell them optimal placement of the burr of the where for access and to place a clip over an aneurysm neck with the least maneuvers and so. Also placement of the deep brain stimulation electrodes in order to make sure that you're not touching structures or areas of interest. But other than that, I think there are a lot of folks that are looking into this. And yes, to answer your question, it is possible to do AI for a intraoperative surgery microscope, and there are people that are doing it for sure.
Yeah, Louis, we have to try to get a hold of Johns Hopkins.
Yeah.
Okay, can I ask a question, Dr.?
Go ahead, go ahead.
Yeah, I'm Dr. Saravanan. I'm actually a pediatrician. I actually know Dr. Bodorta. I'm like on the genetic side. But the question today is, how long have you been doing this? Because I kind of have a approximate timeline. But my main question is how can this be utilized? Has it been utilized in scanning the brain? I know it has been to some extent in patients who have neurodegenerative diseases. And can it be used in pediatric patients yet? Has it been analyzed to help in seizure control or in Parkinson's or dementia? Or how about also one main thing is schizophrenia? Because you talk about a lot about neurosurgery, but how about other neurological diseases? Has it been utilized? Has it been useful, found useful? Because I'm pretty sure, because it's regarding the blood supply in the brain. So can't we expand it much further? Can't we start research in that angle? Please, please educate me, because I'm no neurosurgeon, but I have uncle who was a very prominent neurosurgeon whom I have not even talked to because he was so darn busy. And his son is a neurosurgeon, but I've never even watched him perform neurosurgery because I am in US since 1994. And
Okay,
I've been
okay, ma'am, thanks for your question.
Yeah,
Can you answer that, Cyprian? Cyprian, can you
Yes,
comment
yes,
on that?
yes,
So
yes, please. I'm sorry. I'm sorry.
It's okay.
From the point of view of the AI applications, as I said, it needs a data set. It needs some images or some data, and then some labels. Those labels in general can be a patient outcome. Let's say we would like to know what is the likelihood of these patients to return to normal. Should I open it or not?
Okay.
It gives you, for example, it can give you those kind of things. Now, with regards to dementia and all the other things, it is the that you mentioned. It is the playground, I would say, of the neurologists, and they are so much involved into this. I think if I would have to choose somebody that does this the best, I think neurologists are out there. Especially, I know folks from, let's say, like Dr. Zavadnov in our neurology. There are again folks at UCSF that do a lot of the AI for the afflictions that you had just mentioned. The issue, I think, it is for us to move one step farther and bring things like, how you have a Tesla driver and drives your car. We don't want that. We want something like to tell you, hey, don't change lanes. You have somebody in your blind spot, or it is risky to do it. That's the kind of assistive driving that for neurosurgeries that we want. And from that point of view, I think this is kind of the first. I'm not sure that I've seen it out there, and that's why we're kind of like conservative when it comes about it, because it will, from the point of view of the regulatory office, it's going to be very difficult, very dangerous in a way. We are in the angio room telling you that something is wrong. What if it is not wrong and you go and screw up or something like that? So it is a software as a medical device. And applying this into the angio rooms or into the surgery rooms to guide your electrodes or to go for deep brain stimulation, it will not be accepted this year and probably not even next year unless we show that this works uh, at a big scale. Um, I would say that every single one, the deep brain stimulation folks have asked us for this. The neurosurgeons that do spine for cervical lordosis, they want to know when they are done with adjusting the spine in real time using the O arms. Others, they want to know how to about the tumors and access points to avoid the like speech areas and so far to reach them. So there is a lot of requirements, but as far as concerned, as AI assisted surgery in real time, I don't think there is much out there. If anybody knows something, please let me know. I would like to know.
So Cyprian, you need the DICOM files of the DSA.
No, I actually just need a cable into their data stream, a splitter. What comes from this from the detector itself? That's the only thing that we need. Otherwise, any kind of, if we put it on the PACS, it will not work, because from there it goes into your console, and not until you finish your case you upload the things on the PACS. And your rad tech is going to be there and say, load these images only. nobody, as far as I know, loads all their data into the PACS from an angiogram run, or just snapshots or acquisitions that make diagnosis or are important. Most of it is discarded. So that's the key for this one, for us to communicate directly with the CRM, and the manufacturers have to be involved into this.
You mean the DSA machine manufacturers?
Yes.
Okay.
Can I ask the cost for this procedure? Is the cost during the surgery different from the cost before the surgery and after the surgery?
This will technically, if it's integrated into their CRM, it will be at no cost for the users. The manufacturers could offer this with their equipment. I think that's one of the keys.
So would then see, because I want to know, because medical insurance, will it cover it 100% then?
From what we talked with medical insurance folks, they will not want to pass to the patient any additional costs.
Okay.
Everything, yeah. So it will have to be something that resides, and the manufacturer present their C-arm or their equipment and say, hey, we have these extra features.
Very good. You want to establish as many collaborations as possible, right, Cyprian? Diversely, optimally,
yes, and,
optimally.
yeah. That's kind of like the idea, and also people like what Dr. Purnima has she said. We would like to know other applications. I mean, we live in this place called Gates Vascular Institute, which is a comprehensive stroke center in the Western New York, and the only thing that we see, it is stroke, 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 or you know,
Yeah.
that's kind of like a lot of our focus. And as I showed you before, we're I would say 6 people. 4 of them are very good programmers, but we cannot tackle all the problems for sure.
Okay, very good. Any more comments, questions from the panel? Okay, Cyprian. It's great. It's great. I mean, you hit a home run. I think you made some great connections, and things will go forward. Thank you, Louis, for coming. Thanks, Ben.
Dr. Bennett, just one question.
No, ma'am. We're closing up. Okay.
No, it's not regarding the subject.
Yeah, hold on. What do I do in a situation like this?
Just the last question. It's not regarding the subject. Are doctors trained, or computer programmers trained to do this? That's my last question.
No, this is all engineers, really.
Okay.
Yeah. So, but we do only what they tell us. We never go. Yeah, doctors decide what we do, pretty much.
Okay. Very good, Cyprian. We'll edit this and send it to everybody. Thanks, everybody, for coming, and stick around. We're going to go off camera. So, thank you.
Thank you.